Okay, and good evening, everyone. I am Lauren Gates. Welcome, and we have a very special edition of our Airway Health Solutions Conversations tonight with Dr. Ben Miraglia. Welcome, Ben. It's good to see you. I feel like it's Wednesday night. I have to keep reminding myself that it's only Tuesday.
Yeah, only Tuesday.
Only Tuesday, but we have a lot of time tonight. So it's a really relaxing pace finally that we don't have to get all these questions rushed in. We do have a ton, like four pages worth here. So we will do our best to answer everyone's questions. A lot of these tend to be repetitive, but I wanted to welcome everybody and thank you for your interest in airway and clear aligners and TMD and bruxism and all of it. So we will have a really exciting evening tonight. I did want to remind everybody that we're not going to be mentioning specific products at all this evening. So any questions that were related to specific type of appliances or products or services, we're not going to review that this evening. So let's dive right in. And I'm just going to go ahead and start from the top so I don't lose track here. Are any laser phonectomies still gold standard, especially for patients older than 6 months old?
Yeah, I believe the laser is the way to go. And I learned most of it from Dr. Lawrence Kotlow. So Dr. Lawrence Kotlow is the pediatric dentist in Albany, New York. He's been doing a lot of lecturing over many years. I don't know if anyone has done more laser phonectomies than him, and I believe it's over 50 or 60,000 so far. And I believe even with the laser, he does them after birth at 6 days old or 6 hours old or whatever it takes to make sure that the breastfeeding can be effective and successful. So there was a point in time I was trying to see him teach every year. He was usually at Greater New York, so I could jump in there and catch a class. He put a nice little book together, which is a nice educational resource for parents and team members called SOS for TOTS. TOTS is tethered oral tissues. His website is very helpful, so I could refer you there. It's www.kidsteeth.com. And kids is spelled KIDDS, teeth, so kidsteeth.com with the DDS in the middle there. His website has a section on articles or research. I think when you click that tab, it has a lot of articles and research. I believe he is either now still on or was on most of the laser boards. So he would be part of the design and settings and function for the different types of laser phonectomy. And since I mostly learned from him, I believe that his position was still laser is the way to go for making revisions. And that's how they're being done when we send our patients.
Right. And if anyone's interested in learning more about that, we did have Dr. Scott Siegel on for a full hour. And all of these conversations are archived. So you can also go to www.airwayhealthsolutions.com/podcasts, and you can search for Dr. Siegel, who has a whole hour on that topic. We'll probably bring him back as well to further discuss. Is maxillary palatal expansion possible in adults that does not affect their occlusion?
Yes, maxillary palatal expansion is possible in adults. And the good news is it does affect their occlusion. It takes their malocclusion and it heals it to a beautiful, perfect occlusion. So, on adults who you're thinking about they're being narrow and needing palatal expansion, then almost by default, they have a malocclusion that you're treating. So narrow is one of the things that delivers a terrible malocclusion where you have teeth that have excess lingual inclination, and excess lingual inclination lead to horizontally loaded teeth, and horizontally loaded teeth are full of occlusal trauma. So with interferences in occlusal load, you have all kinds of breakdown. It could be recession, it could be abfraction, it could be mobility, it could be fractured teeth, it could be tooth sensitivity to toothaches. You have the whole list of things that are deteriorating in the mouth, and the majority of them are from horizontally loading teeth. So when you're thinking about correcting narrow to wide and appropriate arch form, you can redirect that horizontally loaded posterior occlusion to vertical load. And the good news is, when you do maxillary palatal expansion in adults, you have different choices in doing it. And mostly I prefer to do it as naturally as possible. So I use removable expansion appliances in adults. We have an entire full day adult mini residency where we teach that technique. So with appropriately designed removable appliances, you can grow a maxilla pretty much at any age, because the Short story is that the sutures of the maxilla really never fuse. That's a myth. They do mature, but they're available for growth for 7 decades, which makes it almost any age that you could use appliances like that to grow the maxilla. And in contrast with the skull right above the maxilla, the skull bones fuse early. They begin to fuse at age 3 or 4 and then finish fusion between late teen to 20s. So skull bones go through full fusion to protect the brain. The maxillary sutures never really go through a full fusion. They just mature, and they're available. Should you have a proper appliance design and a proper technique, you can get the maxillary sutures to adjust. And there's a fair amount of research on that and the effect it has on the nasal chamber and the nasal cavity. So you can have the bone growth as well as the effect in the airway. So I'm a big fan of those appliances, and they're helpful for many patients who need more than just a little bit of uprighting.
Great. And a follow-up question to that from Dr. Rao is, if you palatally expand in adults, how does the mandible follow to expand?
So it depends on what we're accomplishing there. If the lower arch just has lingual inclination alone, you can upright the lower teeth with clear aligners. So we have choices in the lower arch. The lower arch at minimum would get clear aligners to upright the posterior teeth to keep up with the upper arch. If you were handling a posterior crossbite, either unilateral or bilateral, well, then you're going to want your upper removable expansion appliance to do a lot of development, and then you do uprighting of the lower teeth. So that's an example where you have unilateral or bilateral crossbites, and you would go into upper expansion appliances that are removable with lower aligners. Those work well. If you didn't have a posterior crossbite, but you need both arches, well, then if the clear aligners and uprighting would be alone to match the upper expansion, terrific. If not, if we're too narrow, if we're even more narrow than that, then you make a lower removable expansion appliance. And most interestingly is when you use those appropriately, you'll see a little separation in the lower incisors. The 24 and 25 will separate just a little bit. You start getting growth right in the center there. So those two teeth start to separate. Basically, you start getting that mandible to grow a little bit wider, and then you finish uprighting those teeth. So the good news is you have options to get the lower to go with you. It can either be a lower removable expansion appliance if you need a significant amount of change. It could be clear aligners to upright the teeth. Either way, whether you're making an upper removable expansion appliance or a pair, upper and lower, you're still getting clear aligners afterwards, because ultimately what you're doing first is foundational change, and then you do tooth alignment second. So it's foundation first, teeth second. And that process involves clear aligners to finish anyway in the upper arch, because you're going to want to coordinate those teeth after getting the bone to grow.
And our good friend, Dr. George Rivera, wants to know, considering we are now 7+ generations removed from broken isolation, do you anticipate a worsening? An example, narrowing of the maxilla in future generations, and increase in the percentage of narrowing and crowding?
Well, I'm kind of hoping we're peaking, because we are 7 generations into, the industrial Western style of living. However, there have been some really nice trends recently. And one of those nice trends is that there's been an increase in breastfeeding and its duration. So we see that trend coming back up a little bit, which will help. And then I think as parents become more aware, and the word, gets out through education of the public, I think people will start to look into things like, getting the diet earlier, more appropriate for a child. And that's what that book is for. I know I like to say that book everywhere I lecture just to help people out, but it's called Baby-Led Weaning. And that's not the only one. I mean, that's just one of the resources out there where you can start to help transition an infant into solid food, and that will change the course of the musculature, function, strength, and growth and development. So I'm kind of hoping that there's been a little change in the right direction, where parents are starting to recognize that maybe we don't have to blend everything to a pulp and just feed a baby liquid for a year or two, and we can get involved in that earlier, harder textured, more natural diet. So any transition towards a more natural lifestyle is going to be helpful for jaw growth and development. So because we see so many kids, it feels like 99% of them are underdeveloped. And, I'm not a research center, but when, 1 out of 100 kids looks okay and the rest need help, and you consider even in the 1 out of 100, is that child going to grow all the way to 32 teeth right where they belong and have nasal breathing and sleeping and no symptoms? That's a rare thing to happen. So if we're at 99% underdeveloped, it shouldn't take a lot just to go the other way, meaning bring that down to 95, 90. I mean, can't we just get 75% malocclusion and 25% of the kids growing right? So I'm hoping that has peaked, which there's not a whole lot worse it can get if you're at 99. I mean, are we going to say every kid is underdeveloped? It's easy to say it. I guess it's not appropriate for me to say every single child is underdeveloped, but in my world, it's 99%. So I'm hoping we've peaked. I'm hoping with education and awareness, start to make that change where parents start understanding that, yeah, the early diet can have an effect on the breathing, the sleeping. And next thing you know, maybe we could see as the next generation goes by that starts to change and trend towards we grow and sleep and breathe better.
I'm seeing just for parents reaching out and patients reaching out for social media, they reach out to me all the time looking for airway centered dentists, airway friendly dentists, so especially the young moms and all the mommy blogs. So it's really, really definitely increasing, but this is our world, I'm hoping that it's going to be, maybe, this is what we're so passionate about. So hopefully the dentists and hygienists and OMTs out there, SLPs, hopefully you'll see the raise of awareness as well of patients asking you about it. That would be a wonderful turning point. Let's go back to clear aligners. Does it grow bone or just cause tipping, the clear aligner therapy?
Clear aligner therapy, yeah. So, with an appropriate technique, you're getting dentoalveolar changes. Clear aligners don't really move teeth through the bone. That's something that really only braces have a corner on that market. So when brackets and wires are used, and if you think about the early days of braces, there were stainless steel wires only. So when you go way back, you had a bracket and you had a wire, but that wire was stainless steel. So stainless steel wires deliver an incredible amount of strength, a little bit too much force. So you would see a significant amount of root resorption, fenestration, dehiscence, recession, trouble from stainless steel wires. The force was too high for too long. So what would happen is as time's gone by, we've seen nitanium wires and then copper nitanium wires, biokinetic, thermally activated, basically anything that could reduce the strength of the wire. Now, reducing the strength of the wire and spreading it out over time makes an improvement. But the only thing you can't do with brackets and wires is make it a cycle of force, really. You can't make it intermittent because the brackets and wires are on all the time. It's 24/7, 365. So the tooth has no break, which means when braces are on, the teeth are constantly moving in one direction. There's a pressure on one side and a tension on the other, and that is moving through the bone. Whereas with aligners, they're an intermittent cycle of pressure and tension because the aligner is in for an amount of time, but then it's out. And when you have your aligner out, you have instant relapse happening. So basically when your aligners are in, they're working to deliver the teeth in a certain direction. So you would see there's a force and you're pushing the teeth. Let's say we're just expanding. So the teeth are going wider. Well, when the teeth are going wider, there's pressure on the buccal and tension on the lingual. But as soon as you take your aligner out, the teeth are looking to relapse. And if you have your aligner out for 10 minutes or a half hour, you would know putting them back in, hey, it feels tight again, because the teeth immediately start to collapse. But when your aligner's out, that tooth is now coming back to the lingual, which means the pressure's on the lingual and the tension's on the buccal. So basically wearing an aligner cycles the pressure and tension around a tooth. So that's how you have alveolar housing growth. You're basically taking the whole dentoalveolar housing and cycles of pressure and tension. That's how bone grows, by the way. So to get bone growth, you want cycles of pressure and tension, which means you got to get out of brackets and wires if you want to get really good bone growth. Brackets and wires are good for aligning teeth. Once they're kind of where they belong, you can align teeth with braces. And if you're using them for a short amount of time, you can't really cause any harm with the way the wires are today, but you don't use braces to upright and open an arch up. Nobody puts brackets and wires on someone who's super narrow and expects to develop a broad, wide arch from braces only, because that's asking too far to have too much constant force on the buccal and have a satisfactory result. Usually you're going to see some form of recession and or root resorption around those teeth. So it's the reason braces don't really do much expansion and the wires are almost built straight back. So if you look at a set of wires, most of the wires on the market today, kind of at the canine, they go straight back as opposed to having a broad shape. So there are wires that have a broad arch form, but typically those function best in self-ligating brackets. So while it's possible to have an expansive technique in braces, you're really looking to do an amount of expansion of the bone through the sutures first. So when we're talking about children, we're thinking about fixed expanders. When we're talking about adults, we're thinking about removable expanders. Get the foundation closer first, then do your tooth alignment. You get a bigger change, you get more room for the tongue, you get a better airway, that's all helpful, especially as you see more symptoms. With less symptoms, you can go to clear aligners alone, but clear aligners don't move teeth through the bone. Clear aligners move the dental-alveolar complex with the bone. The only way you can mess that up is if you change them too quickly. So if you start changing them too quickly, all of a sudden you're changing your clear aligners into braces, because now changing them too quickly means that force becomes elevated. And when the force becomes elevated, it becomes closer to constant than intermittent or cycled. So to change them too quickly can cause a little bit of harm to the gum tissue. And that's usually the only time I see that is when people will show me their cases and ask, I did get a little recession here or there. Typically, it's because there was a change of maybe less than 2 weeks each. And sure enough, with that comes the risk of having some little bit of recession, maybe. Nothing serious, though.
Will you see 3D bone growth on a CBCT if clear aligners are used?
If you were taking pre and post CBCTs, yes, but you shouldn't do it at the very end. Usually the gum and the bone takes like 3 months after the tooth is done moving to finish its remodeling. So if you were going to take a post CBCT, you would wait 3 to 6 months after the teeth are done moving when you have them in retention, then take one, because otherwise that bone is still remodeling, and remodeling bone is less dense. So there's a significant drop in bone density thanks to all the histology going on while teeth are moving. So during the course of orthodontics, there's a lot of mobility, which is to be expected. And of course, that drop in density will make the bone scan look different. So you want to take it, I would wait at least 3 months, and probably because it shows 6.5 months is what it takes to get rid of all of the cellular activity. It's probably smarter to wait 6 months to have a full picture. And it would mean 6 months, no tooth mobility. Now you should have the same bone density you had pre-treatment. That would make a good comparison.
Great answer. We had Dr. Jasmine Elmore on a whole segment on UARS, upper airway resistance syndrome. So let's talk about that a little. There's a question here. It says, does UARS always lead to sleep apnea? And what about hormonal and psychological factors?
Yeah, there are probably a number of ways you can get to OSA, but predominantly OSA is a disease of the anatomy. And so the most obvious way you can get to OSA is deficiencies in the anatomy. And in particular, it's the maxillary anatomy. Both jaws are undersized, but the maxillary size dictates the lower position. So anytime the upper jaw is underdeveloped, the lower jaw is trapped behind it. So we know from the early soft diet, you get an undersized maxilla and you get an undersized mandible, and now you have less room for your tongue. From the early soft diet, you get a narrow and vaulted palate, you get an elongated soft palate, and those are all the risk factors for OSA, sleep disorder breathing, and OSA. So OSA is a chronic, like an endpoint. It's a deterioration to OSA, not a light switch. So if you think about medical issues as acute versus chronic, an example of an acute medical issue is if you slip on the ice, you fall and you break your arm. Well, that's an acute medical problem. A moment ago, you didn't have it. Now you fell down, you broke your arm. You have no broken arm 1 minute ago. Now you got a broken arm. That happened instantly. OSA is not instant. You don't have it today. You didn't have it yesterday. And the idea is you don't have perfect breathing one day and then you're OSA. So you deteriorated to OSA. Nobody goes from non-resistant nasal airflow that is beautiful to OSA. There's no light switch. It's not an acute situation. So since predominantly the OSA is a disease of the anatomy is underdeveloped early, and the underdeveloped anatomy early, the first thing it delivers is nasal airflow resistance. So with nasal airflow resistance comes a compensation, which is mouth breathing. So if the nose doesn't breathe well, the mouth opens a little bit. So breaking of lip seal. Next thing you know, you have mouth breathing. That doesn't improve airflow. So even though mouth breathing supplements, it doesn't improve airflow. In fact, it ends up exchanging too much oxygen. You're over breathing with the mouth open. It throws the biology and physiology off, but it also lowers the tongue even further because now the air's got to get by. So the compensation having that low tongue posture is that the malocclusion tends to get worse because now the patient will be using cheek muscles for breathing and swallowing patterns. And with all of that going on, it further collapses the maxilla and vaults the vault. And next thing you know, we have the elongated soft palate behind there. All of these things continue the process. So we go from nasal airflow resistance to maybe some mouth breathing. Then maybe at some point you hear some snoring, you get upper airway resistance syndromes built into there in the middle of this somewhere. Gradually you get to OSA. OSA isn't even the biggest problem. The biggest problem is at the beginning, nasal airflow resistance. The moment you have nasal airflow resistance, you have an unhealthy human being. And then it's like having a small cut, let's say at that point. Why would you wait to treat a small cut till it gets to be the big gash at OSA? So nasal airflow resistance, tiny little cut. Why not get that Band-Aid on or get the stitches in that little cut? Are you going to wait until it's much bigger and worse? And then all of a sudden we're at OSA. So waiting to OSA is terrible. And so the adult population and kid population that are in OSA, first of all, those numbers are smaller compared to who just has nasal airflow resistance, upper airway resistance, snoring, mouth breathing, all of the other things combined, sleep disorder breathing, that group needs your attention. Otherwise, they're all headed towards OSA. Some people get there faster than others, but it's a chronic deterioration to OSA. And when you get to OSA, now you're trying to treat the patient in their worst, health condition. And that's not an easy time to bring them back. So the goal would be to not focus on the OSA part and go way earlier and focus on just nasal airflow resistance or mouth breathing or snoring. Any of the things in the sleep disorder breathing category should be instantly a focus on the person's anatomy and growing it and getting it as big as you can, not to mention all of the Frenem revisions that would be needed, as well as the myofunctional therapy. That's probably like, the best three things that could happen is nasal hygiene, and then Frenem revisions, myofunctional therapy, and then growth and development of the jaws. When you combine all of that, you can do a wonderful job against anything, whether it's in the OSA category, but your earlier is better.
How is the medical community embracing orofacial development to prevent OSA?
I don't think the medical community knows about orofacial development. I think what the medical community is aware of is mandibular advancement devices and holding the mandible forward. That seems to be where the medical community is. I don't think the medical community knows much about head and neck growth and development. And it should be no surprise, dentistry was pulled out of medicine. So dentistry is a specialty of medicine. It just happens to be, our world. And I think that the medical community doesn't have a whole lot of training on orofacial growth and development. And I'm pretty sure the medical community has very little training on sleep disorder breathing to OSA as well. And the idea there is basically, I guess it would be a part of our job is to build bridges and collaborate and try to educate them so they understand there's more than one choice. While mandibular advancement devices can help a lot of people and it is a choice, it's not my first choice. I would prefer to be in the growth and development category. So at any age, I'm trying to grow, the jaws, give the tongue more room, get the Frenem revisions, get the nasal breathing again. So I'm looking in the growth and development category first, as I would almost have the mandibular advancement device be as a last resort, kind of like a CPAP, meaning if you can't get any growth and development or the patient's not willing to do those things, then default to mandibular advancement and CPAP. Neither one of those is a first choice in my world.
There was a question on what are the disadvantages of a MAD appliance. You want to just touch on that? I know that's not your choice. Do you want to just say why?
Yeah, the disadvantage, the biggest disadvantage to the MAD device is that it has a pretty good opportunity to be delivering headgear effect. And the headgear effect is that it will kind of pull the maxilla back, create an edge-to-edge bite or just a heavy anterior bite or edge-to-edge type of bite. And the idea is when you're pulling the mandible forward, well, there's an opposite pull on the upper jaw. So because the maxillary sutures are not fused, they can be remodeled. When you put in a device that has a pull forward on the lower jaw, well, then there's a pull backward on the upper jaw. That's just Newton's third law, equal and opposite. So however much force is holding the lower jaw forward is being applied to the upper jaw. And when you're getting 6 to 8 hours every day, that's enough to remodel the maxilla, which creates the bite change in the anterior. And when you have that remodeling going on in the upper jaw, you're closing the upper airway. So the potential for a MAD device is that short term, it can get the tongue out of the way. But over time, there are patients who have worsening of the OSA with extended use of the MAD device. In the dental population, we might just make it tighter or have more pull on the tongue, but that helps the tongue more forward, but it also puts more pressure on the upper going back. Dr. Markland published a paper, I think back in 2016, maybe, showing that with 10 years use in the MAD category, a significant rate of the OSA being worse than the starting point, and that's with the MAD in place. So holding the tongue out of the way and having a worse OSA diagnosis is trouble because that means something was created somewhere else, and it's because of the upper airway collapse. So I'm skeptical of using a MAD device for a long period of time. And because of that study and because of the maxilla remodeling, thanks to Newton's third law and the headgear effect, I think that any patient who has a MAD device where the anterior bite is starting to become heavy or changed, that's an indication the maxilla is rotating back. That's a patient who would be discontinued from using the MAD device, only because what's the point of doing something that has short-term gain, but long-term can make them worse? And the only solution for that maxilla being pulled back is then jaw surgery forward. So we're not trying to give the patient MMA surgery when we could have had other options to grow the maxilla. So growing the maxilla is probably the best thing to do. The MAD device, you have to pay close attention to the change in the bite. A change in the bite is a pretty good indication that the maxilla is suffering from a headgear effect, and that can be in the long term worse for our patients.
So how can the maxilla be advanced? One of the doctors understands how to advance the pre-maxilla. How can?
Well, expansion alone brings the maxilla forward. So it's very nice research. Dr. McNamara showed this stuff. So Dr. McNamara probably did decades of research at the University of Michigan, showing that lateral expansion alone drives a point forward. So anytime you are pushing that maxilla wider, because of the attachment, because of the 7 sutures it has behind it, the bracing of the maxilla, there's always a push forward. So as it's expanding wider, it has almost no choice but to come forward. It's not trapped between stuff. It's on the front end of the rest of it all, so it can come a little bit forward. So he was able to show that lateral expansion alone drove a point forward, which is very nice to have. And then, of course, you can get more with pre-maxilla. So if you're in the class 1 or 2 category where you're underdeveloped, you just need lateral expansion. It turns out probably only the class 3 needs wider and forward, where you would incorporate a design that has maybe 3 screws in it. You would also have the pre-maxilla being pushed forward, and then you would get extra. So since class 3 is on the rare side of things, when we think about 3 to 5% or whatever it actually is, that's less of the time. So it's only in those patients where we need to have the extra pre-maxillary forward push. The wider alone will do it.
At what age can we start developing the mandible?
As soon as you meet the patient. So it could be age 3 or 4, we jump in at 3 or 4. So it doesn't mean that you can't do anything earlier. There are things earlier. It turns out that I'm hoping Dr. Boyd is on the call tonight too, because a reference.
Yeah, he was planning on. I don't see him on yet.
Yeah,
I know he's so fun. He always has questions to ask.
Our expert, Dr. Kevin Boyd, knows what you can do from 0 to 3. So
Yeah.
in my world, I begin from 3 to 4 years old, and as I get the children to wear guidance appliances, nasal hygiene, myofunctional therapy, frenum revisions, guidance appliances, 3 to 4 kids can get in there. And the moment you redirect the breathing and the musculature, jaws start growing again. So your maxilla and mandible grow thanks to muscle function and strength. And so anything you could do to redirect breathing and musculature will get the jaws growing more appropriately to catch up and then surpass where we should be. Just because I begin at 3 to 4 in my practice doesn't mean you can't work on the kids earlier. And that's where we rely on Dr. Kevin Boyd, expert pediatric dentist. And he has all that good knowledge from 0 to, really any age, because he can treat any age. But the idea there is, there are things you can do younger than that. And we needed to learn that. So we have asked Dr. Boyd to put together a nice course to be able to teach our docs what can we do earlier, because sometimes you meet the kids at 3 and 4 and you're like, well, yikes. Sometimes you feel like you're too late. And why didn't we help this child? They haven't slept through the night yet. Or, the struggles, the symptoms are so real. Families could be struggling with children at that age. So why not help a child at 2 or 3 instead of 4 when you could? So we're counting on them.
Exactly. And he'll be on with us for a conversation about intercepting orthodontics and what age to start. So that'll be February 2nd. We'll give you the invites for that. That's a full hour on that. So that'll be wonderful to touch. Do you prefer kiddos having phonectomies done before or after fixed expanders? The myofunctional therapist is saying it's hard to work with them on certain exercises while they are in fixed.
Yeah, it's tough to get the myofunctional work done with the fixed expander. So I try to keep the fixed expansion to as shortest amount of time possible, get those kids, jumped up to where they should be or a little bit past, but then immediately into the myofunctional therapy. So our routine is, I'll get the fixed expanders in, we'll gain all of that space. And then as I'm removing them, I like to get them to our myofunctional therapist. And we use Brittany Sierra a lot. So she knows most of the patients. We're sending them there. I like to try to get them to her about a month before I take the expander out so she can meet, do some evaluating, kind of know what's coming. And then on removing the expanders, we don't make retainers that are kind of static or holding appliances. We deliver guidance appliances. So myofunctional guidance appliances are very nice to use as an interim while the patient immediately goes into myofunctional therapy and frenum revision. So it's myofunctional therapy, frenum revision right after expansion. And that's fine. And, there's nothing wrong with doing some beforehand, but there are limitations with the fixed expanders in place. And I know that can jam up the myofunctional therapy exercises, but right afterwards they're in there. And that has to be, a significant amount of time in the myofunctional therapy because you do need to get the breathing and the musculature back. And no better person to do that than a great myofunctional therapist.
So James Seglevev would say, I'd love to hear more about your courses and techniques of treating patients from children to adults. So let's talk a little bit about day one, because a lot of these questions are really geared towards, how do they do this? And it's a lot of the technique. So let's just talk about, we have a 2-day mini residency, and the first day is pediatrics. It's a whole day of pediatrics. But Ben, why don't you kind of go over what we teach in that course so people will understand what they will learn come Friday evening, happy hour.
Yes. So that course basically in the pediatric day, we're focused from age 3 all the way through probably 12 or 13 is about the group, that age range. And it begins with the diagnostic record. So we do a small component. There's a small introduction on anthropology research, the early soft diet, and kind of how we become underdeveloped. So we do learn about the underdeveloped jaws and how it's, basically just a population becoming industrialized thing. And then once we have that little bit of a foundation, we go into what are the diagnostic records we use. And so there's a number of things that you can do to collect data and learn. And some of the things that are unique in there would be the transverse measurement. Some of the things that are really unique are the questionnaires that we use, because we're asking the parents about a lot of things they might recognize as symptoms that we can tie into underdeveloped jaws, sleeping and breathing. So when we collect a lot of the diagnostics, it leads to consultation. So now you got to have a nice consultation. So after we've learned what are the appropriate diagnostics, then you go into how do you talk to a parent? Because all it is a bit of education, and parents know the symptoms that their kids are struggling with. You would know then what the underdeveloped jaws will deliver in the sleeping and breathing category and how they're connected to these symptoms. And then of course, with a nice consultation, you should be able to lay out to a parent how you can help. And by growing and developing that child, and then it involves after they say, how soon do we start? Then you need to know, how do I do it? And so it is a technique course. So we cover fixed expanders. We cover techniques for upper and lower fixed expanders. So having an upper expander only is essentially useless. And so you need a technique that has an upper and a lower fixed expander. So we do teach fixed expanders, upper and lower, so that you can get the 8, the 10, the 12, the 16 millimeters of growth and development that you need in order to grow and develop a child that can breathe better, sleep better, lose all their symptoms, but as a last step, have their wisdom teeth erupt into function most of the time. So as an outside goal, everything that is done early will prepare that child to be on the path to have no symptoms, but also grow and develop in a manner that you would have almost instantly, flipping whatever your wisdom tooth extraction rate is now to better than 50% of your patients would keep and erupt their wisdom teeth into function by having this technique. So you learn fixed expander technique, appropriate upper and lower techniques so that you can eventually keep the wisdom teeth. So that's a long-term goal, right? But then fixed expanders are for short amounts of time. So because fixed expanders are for short amounts of time, what are you going to do after that? 6 months, maybe 9 months at maximum? You need to have a guidance appliance technique. And so we do teach what are the guidance appliances out there that you could get involved with immediately and begin to use those, because after fixed expanders, you need some guidance appliances. Not every child needs fixed expanders. So now that you have a guidance appliance technique, you can use those on children without fixed expanders. So you have children that will fit the numbers and measurements and diagnostics of needing expanders right away, but those who don't need expanders right away can go right into guidance appliances. So either way, you learn a guidance appliance technique that can help you on children who can use them immediately or after kids have fixed expanders. You're going to learn all about the frenum evaluations. And so there's a Dr. Marquezon protocol. Every one of the students would learn a frenum protocol. With the frenum protocol, now you have a quantitative analysis to use as part of your diagnostics to teach a parent. This is what it means to have a tight or restricted frenum. How your child scores will dictate how they grow and develop. And of course, the tight frenum is directly related to the growth and development, or underdevelopment, I should say. And an underdevelopment is directly related to the sleep disorder breathing. It's all tied together. Then, of course, there's that phonectomy, because you're talking about having a tight frenum. Well, now you have to have a phonectomy as part of your regimen, so that you would know to have phonectomies done when appropriate. And then there's also the myofunctional therapy component. So now we have to learn about myofunctional therapy, orofacial myofunctional therapy. In the course, we introduce probably a half a dozen basic exercises. And I like to say that, that's playing chess, that's playing checkers, whereas the orofacial myofunctional therapy community is playing chess. So while we do teach 6 introductory level exercises that can benefit a child to grow and develop more appropriately and help with soft tissue dysfunction, ultimately what you're looking to learn is that the myofunctional therapist is a very important collaboration part of treatment for the child. And if they are located in your area or region, you would be referring to them. That's a first opportunity. You locate who they are and you refer to them, and now you can help the children together. Or second opportunity is a hygienist can be trained as a myofunctional therapist. So if there is a team member who would like to work with the children and do myofunctional therapy in the practice, there's additional programs that can teach myofunctional therapy to a hygienist. Then, of course, last resort is to be doing at least a few basic exercises can get you started in the right direction until you can learn more and do more. So what we're doing here is we're teaching an entire technique course to get a child to 12 or 13 years old where the first 28 teeth have come in where they belong. And what you have is a fully grown foundation, a child who breathes through the nose, sleeps through the night, and has no symptoms, where they began with a list of symptoms. So now you have basically solved their underdeveloped malocclusion. Their teeth look amazing because they kind of migrate to place as you grow the jaws. And you have a child now who has well-developed jaws, properly balanced and strengthened musculature, is nasal breathing, sleeping through the night with no symptoms. Basically, you're delivering that child to that 28 tooth count where what do they need next? And that's the next level, is finishing them could be something simple. Maybe you just need a few clear aligners to finish the case. So the pediatric day basically is the how to do it across all of the different things that are expansion related only. So obviously there would be no talk of extractions and or retraction type of techniques. It's a growth and development course. So everything is wider and forward. And nowhere in those courses is it appropriate to take out baby teeth and or permanent teeth. So there's no such thing as you take out primary teeth to help out the permanent teeth. That is misspeaking, and it is a subtractive technique, and it only allows for arch collapse. So we never take out a primary tooth, and we don't teach it and or do it. So we have, with my experience being 18 years of doing this, I've never removed a primary tooth early. And there's nothing wrong with a primary tooth staying even a little bit past its supposed time for, exfoliation. So you want to keep the primary teeth in place. You want to develop the jaws. It's about the foundation. So it is a foundation focused technique. You're going to learn how to grow the jaws so that that child could recover and heal. And then eventually you get to the point where the teeth second would be simple, maybe a few aligners, maybe a few months in braces for alignment. But at least when the foundation is fully developed, you can do either one of those in a short amount of time and kind of finish the job. That's the icing on the cake.
There's a lot of controversy on like the Facebook chats and the groups about that sometimes extraction is necessary. Have you ever
No.
seen a case that extractions, besides say severe decay pathology, but from an orthodontic standpoint, have you ever seen a case that needed an extraction?
No, in fact, we did I want to say we did a podcast town hall meeting one night where we showed that one nice patient who was 16 at the time and had the most amount of crowding most people have ever seen. And we opened up and developed that jaw and showed how, so there's no
That's
such
archived.
thing.
That's archived.
Yeah, that's archived. That's a meeting. I forgot what the name of that one was that was in there, but we showed it. We showed it as an example of if you don't need extractions here, you couldn't possibly need them anywhere, because that is a patient who most people don't find anybody more underdeveloped than that. And that was 16 years old, starting it with fixed expanders. So the idea is that a human being is entitled to 32 teeth. And prior to the industrial Western living, human skulls grew beautifully. because there was an early hard diet. So transitioning from breastfeeding to an early hard diet delivers the muscle activity and strength to grow the jaws. And prior to 400 years ago, there's little to no incidence of malocclusion in the human race. So since prior to 400 years ago, we're pre-industrial, pre-Western living, you don't have malocclusion. You have fully grown jaws with beautiful teeth spread out and all 32 of them showing up. Basically, a human being grows perfectly with that pattern. So when you introduce the early soft diet and the jaws are underdeveloped and the teeth are crowded, and I get it, sometimes it looks like they don't fit. But that's a point of view that has the perspective of we're focusing on the teeth. So if you have a focus on the teeth, it's quite simple to see they don't all fit right now. And if you're focused on the teeth, you tend to lean towards extracting. But the idea is no human being needs an extraction. That's just unacceptable. And I've been doing this 18 years continuously. It's what I do all day, every day in the office. And 18 years continuously treating children. Not only have we never taken out a primary tooth, we've never taken out an adult tooth on any patient. And last but not least, we went from, before I was doing this, we were sending probably 8 or 9 out of 10 teenagers to get their wisdom teeth out. That's a long time ago. Because I'm doing this 18 years, I'm well over 50%. We're going to hit 75 probably this year. So at the end of this year, I should be able to confidently say 7 out of 10 of the kids I treat grow into their wisdom teeth, fully erupting into function. Right now, we're well over half. So now we're sending less kids for wisdom tooth extractions. And there's no reason that can't be 100, because any child we treat, if we get them to the right spot and have the breathing and musculature, they'll grow right into the wisdom teeth also. So because I have a fair amount of experience and I've seen my wisdom tooth extraction rate get completely flipped to now we keep most of them and they grow into function, there's absolutely no need for an extraction of anything. And there's any diagnostic tool that says to extract, like if you have a measurement or if you have a tracing or something that says, oh, this is where you take a tooth out, well, that diagnostic tool is a tooth-based diagnostic tool. So I understand that there's probably a diagnostic tool that says take it out. I read the articles for 10 years. I had every ortho journal coming into the practice for the first decade I was doing this to make sure I was learning everything I could, of course, in the expansive category, but it turns out you learn other stuff too. And you cannot read an ortho journal where extractions were done without reading the sentence. The sentence is, based on cephalometric analysis, 4 bicuspids were removed. Based on cephalometric analysis, 4 bicuspids needed to be extracted. And you see that sentence written any number of ways, but it's in every single article where the 4 bis are taken out. In other words, you don't take out the 4 bis without having a diagnostic tool to do it. So you back up to the tool. It seems to be it's the ceph tracing. Now, if the ceph tracing is teaching you to take out teeth, then there's some sort of flaw there, because no human being should be less than 32 teeth. Maybe the ceph tracing is a tooth-focused tool. Could be that if it's a tooth-focused tool and it's showing you can only fit this many teeth, maybe it's accurate in saying because of these numbers, you need to take out teeth in a tooth-focused approach. But that doesn't mean you can't have an expansive technique at any age. And I've been using fixed expanders on teens through 19. That's a whole nother course we built when the doctors wanted to learn, what do you do from 13 to 19 if they come in? And sure enough, people walk in at 15, 16, and they need fixed expansion, and they can have fixed expansion. So there's no such thing. Anyone who wants to take teeth out of a child, just send them to me. I would rather treat that child for free. I would rather treat that child for free and have them keep all of their teeth, because it's not a healthy choice. I've seen enough to know that if you're taking out teeth, you're accepting the undersized foundation. And now by taking out the teeth, you've overcompensated, and now there's too much room. So it ends up, now you have to shrink it down to get the rest of the teeth to touch. Now your tongue has no room. The jaws are narrow and back. It's a collapsed mouth. Last but not least, I would encourage GPs to open your eyes and look at the 4 bicuspid adults over the last 2 to 3 generations. And you tell me, do you feel that your 4 bicuspid adults over the last 2 to 3 generations are healthy people? Because you take a look at those people and how their mouths look, and then of course their medical history as well. You're going to find a lot of unhealthy people in the 4 bi extraction category. You can look at anything from the teeth to the gum to the bone to the TMD to the sleeping and the breathing. Take a look at their symptoms and what they have. And you're going to have a long list of symptoms in people who are missing bicuspids. So it is a choice. It's not a need. That's misspeaking. And there are body parts, 32 of them, that just need a proper foundation. And since 400 years ago and prior, it happened all by itself naturally. How could something happen naturally? And then all of the brightest minds in all of dentistry can't figure out a way to recover it. So we should be able to do better. Every child should be grown and developed appropriately to have 32 teeth. So knowing what I know now, I'm no longer impressed when I see 28 teeth. You can't impress me until you show me 32 teeth and then a child who knows, breathes, and has no symptoms. That's called an A+ today. When you develop the jaws appropriately, you show me 32 teeth, you show me a nasal breather, you show me a child without any symptoms in the sleep disorder breathing category, you get an A+. Anything less than that, it's not quite an A+ anymore. So why should the patient get less than when you can deliver the entire process? If I could learn it, and I came from doing restorative dentistry all day, all week, all year for 10 straight years, I never did a thing in ortho until I felt like I needed to learn how to do growth and development early to offer my patients a different solution than what I was seeing. So I picked it up from scratch 18 years ago, and I had to learn and pick this piece and that piece and this piece. And here I am stitching together what I didn't know what I was doing at first to being able to teach in a manner that you could almost instantly flip your extraction rate of wisdom teeth from high percentages to keeping most of them. That's unbelievable. So if I could learn it, I'm willing to and happy to share. It's one of the driving, forces in teaching it, in that the more kids who get early growth and development, attention in the myofunctional therapy category, attention in the Frenum revision category, basically attention to the foundation first, you have a healthier child going forward, because an unhealthy child can't grow out of that. You're going to have an unhealthy adult. If you have an unhealthy child that you can grow and develop to a healthy child, you're going to have a healthy adult. So yeah, it's a wonderful opportunity. And I get a little upset when I hear you need to take out teeth. That is unacceptable. It's one of the most, it's a black eye on dentistry. I'll tell you that. Extracting teeth is a black eye on dentistry. Dentistry should start thinking about teeth like limbs. How quick are we to take fingers off or limbs? That is a dead last resort. Nobody's just taking stuff off. Oh yeah, your fingernail looks broken. Let's cut that finger off. That would be the equivalent of, yeah, that tooth doesn't fit, rip it out. Such a bad viewpoint, such a bad perspective. Dentistry's got to grow away from that. It's not a good look.
Well said. Is protraction headgear an integral part in treatment of sagittal deficiency?
The reverse pull face mask is a piece of the puzzle in some of the cases. The good news is when you get the child early enough, you shouldn't need it. So do we meet some kids a little later who are in the class 3 category? Yes. And I have a few of those, but not many. So if I had to guess, I'd say once or twice a year, I've got to use expansion appliances. But again, it's both arches, always upper and lower expansion to get that child that 8, 10, 16 millimeters of width that they need. So we need all of the width. If we need a reverse pull headgear, I do incorporate that into the expanders. There'll be an arm with a hook, the reverse pull headgear. I'm not the biggest fan of it. I do try to avoid it as much as possible and try to get everything through the Frenum revisions and myofunctional therapy. Because if you can get the tongue right, it will help you to grow wider and forward as well as your expansion technique. So we want the tongue. The reverse pull headgear, theoretically, you got it on your forehead and your chin. So it's not really my biggest, I don't love it that much because you're pushing back on the chin. I don't like bracing against the chin. So in a perfect world, your reverse pull headgear would be forehead to chest. And so if you go forehead to sternum, now you are pulling the maxilla with a brace on the forehead and the sternum, two things that are kind of resistant, and then you're not pushing back on the mandible. I'm not a big fan of pushing back on the mandible. So I try to use those as little as possible. But if you wanted to, you can look that up. There are labs who can make the forehead to sternum. Luckily, those are very rare, and the earlier you treat the child, the better.
This is an interesting question. What do you do if a patient does not want to invest in expansion and would like extraction? Who doesn't want to invest in expansion, but would like extraction?
So I've never met a patient that would like or choose extraction. In fact, I've had consultations now for 18 straight years, and I've never lost a patient to an extraction. In other words, if they came to me as an opinion and I gave my opinion, I'm going to treat that child. And it works either way, whether they got to me first or fourth or 10th. And so some parents do go to many places, and I could be the 4th on the list or the 10th on the list. But I've never had a family choose extraction, and I would never do it. I mean, if it came down to in consultation, We're not going to do expanders. We're going to choose extraction. I can't treat that child. So I would dismiss them and wish them the best, but I'm not taking any teeth out. I can't do that. If they chose it, never. And I don't have an example of a child choosing to have their teeth out in the last 18 years of doing consultations where they came in saying, I was told I had to take teeth out. On top of that, I have a long list of patients that have come in after their teeth were already taken out, and either they're mid-treatment or post-treatment, and they have a natural disaster in the sleeping and breathing and TMD category, of course, and their tongue has no room, and they have a long list of symptoms, which they had before, or they're worse now, and I've had to retreat them. And so there's a long list of teens and adults that we've gone the other way, meaning, okay, into expanders, grow the jaws, replace those teeth. And so the younger you are, the more likely we're going to grow your jaws all the way out where you belong and give you back. If you're young enough, you're going to get bonded ceramic Maryland style bridge work. It's beautiful. It's, they're fixed, but they're bonded to teeth without any preparation. And they're basically an implant placer till you can get to the age of 21 to 25, wherever your comfort level is for putting in, implants. But there's no shortage of that. I can tell you that. There's no shortage of people still taking out teeth and them showing up in my office afterwards, learning that someone else, had different treatment and they want another opinion, especially since those kids usually have remaining symptoms. And when the symptoms are still there, the parents start digging. Next thing you know, they're in our chair wondering, what can we do now?
Right. I've never heard of expand regret syndrome. I've heard of retract and extract regret syndrome.
Yeah.
Right?
Because the symptoms go away so quickly. The moment a child has an expander, and it feels a little weird at first, but none of them hurt today. The way they're designed, they're easy to get used to. And really, there's no hiccup, because the tongue in any patient, in any child you're about to put an expander in, there is no concern for the tongue space. You know why? The tongue has never been in the palate to begin with. Most of these kids don't even know there's an expander in there after you put it in, because their tongue doesn't function up anyway. If their tongue functioned up, their palate would be beautifully shaped like the tongue. It'd be broad and wide, and they'd have this beautiful dome up there without a vault, and you wouldn't need an expander. So when you put your expander in, it doesn't interfere with the tongue at all, because the tongue has never been there in the first place. We're going to get the tongue there with the myofunctional therapy, but we put those expanders in kids. We're doing it with a slow turn anyway. I don't do RPE, I do slow. So our technique is a slow pattern. We're going to grow the jaws. It's still going to be weeks in the making, but the symptoms fade away so quickly that usually once that child has a few weeks under their belt, things are starting to fade away. Next thing you know, the parents know, wow, what a good choice. Meanwhile, after taking out the teeth, there are a lot of regrets there, a lot of regrets. Every one of those kids who comes in and it was already done, that's a family crying and disturbed by not having choices, and then being upset about not having choices. And then, of course, a year and a half later, when everything's back where it belongs and we have spaces where those missing teeth were, but then the child has no symptoms and sleeps through the night, doesn't have headaches, doesn't have TMD, all of a sudden you have a different child on your hands. That parent's ready. That parent's ready to spread the word. So stop taking out teeth, please.
What are the limitations of expansion? When is it time to consider MSE, dome, or surgical options?
Well, surgical options exist. I guess they're always on the table. I don't use them very much. I try to just use as natural a slow expansion process as possible. I would like to cycle pressure and tension to have the bone grow. It's my preference, but doing MARPE and SARPE and all the other types of things that are out there with, implant-borne expanders, I'm not opposed to any of that. That's not for me. So I'm in the removable growth and development category. So removable expansion appliances for adults over 20, because through the teens, you can use fixed expanders and have it happen nice and easily. But in over 20, you start thinking about the removable expansion appliances. It's as natural as possible. But then there's that severe OSA category, and that severe OSA category is daunting. So the patients in the severe OSA category, we take a look at that medical history list. Are they struggling with uncontrolled blood pressure for 10 years? Do they sleep an hour at a time at night and they are a disaster of symptoms? Because then you might think about MMA. And so we're up to 3 of those now. So in the last, the last few years, we'll say 4 years or so. So we're almost a 1 per year average, but 3 MMA surgeries in the last few years, because the severe OSA was debilitating and the symptom list was unbelievable. And for me to spend 1.5 to 2 years to slow grow those jaws when the patient has really been struggling for decades, that doesn't match up. But in the severe OSA category, when you go in for MMA, you're still doing pre-surgical orthopedics and orthodontics and then post-surgical orthodontics. So that it's a full plan, but you can get into the MMA quicker. So I pre-treat those cases. We get them set up for surgery. They go into MMA, and 8 hours later, when they come out of that, all those symptoms are gone. So the patients who have uncontrolled blood pressure for 10 years, they lose their blood pressure medication 2 days later, their blood pressure normalizes. And now here, that patient is 3.5 years later. That's one of the first ones. So 3.5 years later with perfect blood pressure, no symptoms, they all go away. The brain fog goes away. The sleeping problems go away. The memory comes back. All the sharpness comes back. Everything you would expect from having a good night's sleep would come back if you're breathing well. So the key there is you just have to have the right surgical group, because the surgery group needs to know there's an amount that you need to move that jaw set forward in order to produce the right amount of space for the air to flow. So you want to make sure you're moving the jaws forward enough to have a big fire hose to breathe through behind it. And if you have that, you're in good shape. So I've used two that work well. One is Dr. Scotty Bolding. He's an excellent oral surgeon who only does oral surgery for OSA patients, and they lose their CPAP, and they lose their oxygen tank, and they lose the weight, and they lose the blood pressure. They lose the list of symptoms because he knows how far to go. The other group I've only done one surgery with this group, but they had a great reputation. And so it was Drs. Gunson and Dr. Arnett, and they're on the West Coast. So that's California. Drs. Gunson and Dr. Arnett did a beautiful MMA surgery and that was a younger patient. He was about 26, 27, struggling with OSA, and he had the retractive ortho as a teen, so it was a disaster. They pulled him all back. He had no profile whatsoever. Well, we pre-treated him, they got him set up, they pulled him all forward, a beautiful solution. Now he goes to bed, he falls asleep in 1 minute, he dreams the whole night, he wakes up in the morning, a totally different life, having the surgery done. So brutal few weeks, though, can't hide that from anybody. You're going to tell them it's going to be the roughest 3 weeks of your life coming out of that, because it's a very uncomfortable thing. But if you're willing to get through the first 2 to 3 weeks, it fades. And then next thing you know, you have the rest of your life to breathe well and be healthy. So I'm a big fan of MMA. Don't use it often. You just learned it's probably one a year roughly that we would do that for. But in the OSA severe category, probably should be talking about that and maybe having a surgical consult so the patient knows this does exist. The other surgical techniques that are in between, the MARPI, SARPI, all that other stuff, I encourage doctors to go learn it. It's not a technique for me. I'm 18 years in. I haven't added that to my routine, but anything that helps an adult go wider and forward is terrific. The difficulty I have with that is make sure you learn a lower technique, because those techniques that we're mentioning, MARPI, SARPI, that's for the maxilla. So how far can you go with the maxilla if you don't have a plan for the lower? So I would make sure that surgical technique, if you're going to do it, you're not just doing it for a few millimeters because you don't want to go outside the lower arch. Have a plan for growing the lower arch so you could do that surgical technique and get the big gains out of the upper. You may as well get everything you can out of it. So don't get stuck in the mindset that you can't grow the lower with it.
Excellent. A quick question on probably one of the last questions here, and we don't really ever talk about this, but it's a great question. It's how does reducing all these treatments like crowns, extractions, improve an office's overall profits?
Reducing crowns.
Like reducing all of these treatments. Basically, maybe you can just rephrase it. How is this profitable to the dentist office?
It's actually a multiple of the crown and bridge and implant dentistry. So when I was doing 10 years of crown and bridge implant dentistry, the first 10 years of my career were crown, bridge, and implant reconstructive dentistry, all fixed. I didn't make a removal. I haven't made a partial denture ever, except for dental school. So I don't make removable partial dentures, anything like that. The first decade I was doing that, and it was incredibly profitable. I was having a wonderful career. Then all of a sudden I got involved in growth and development and expansion appliances. And next thing you know, I'm treating kids from 3 all the way through any age. And that's all I do now. So it transitioned me right out of fixed crown and bridge. But what happened was you can't just give that up. So we had to build 3 more operatories, hire 2 more associates to do all that work. That work is still there to be done. So you don't give it away. You make your practice bigger and you hire more people so that they could still do that dentistry while you're doing now growth and development, which is a multiple of profitable compared to crown and bridge and fixed. So unbelievable, the profitability.
Yeah, it's funny. It's a myth almost. You can take away some work, but you're actually adding a lot. There is one question that I just want to address about how to get hygienists on board to easily have these conversations. And we'll send this follow-up 1-minute airway assessment. I call it the nests, and you can use this in your oral cancer screening. You can actually copy this template into your software. I use this firsthand chairside. I thought it was very helpful for just a basic overview. So we'll send that in our follow-up And I do want to follow up that we do offer team training where I spend 7 hours with the team going over all of these questions that we're getting on how to get, the team on board, the hygienist talking to the patients so they feel confident and competent. So reach out to me. I like to customize the training to where you are and to really motivate you guys internally. A few things, just so updates that we know. We do have one spot open for Friday's adult mini residency. If you can't make it, don't worry. There's plenty of seats in the March and May courses. So just go to our website, airwayhealthsolutions.com. You could do /events. We've had so many people who've taken our courses on tonight, so it's always nice to see our alumni. Once you become an alumni, you actually get to be featured on our Airway Dentist locator. We just have 20 new dots from this past week. So this will be filling up nicely. And patients are looking for airway dentists. They come all the time. And actually your colleagues are looking to refer their family members and patients who are relocating. So it's a great value base for you. We talked a lot about myofunctional therapy. Hygienists, if you're out there and you want to propel your career, dentists, if you want to increase your revenue and compliance, it's a win-win situation. Take our Myo course where you integrate Myo into your practice. We teach your hygienist how to do myofunctional therapy in the practice. So go there. There are a few spots left. We keep it very small because it's very interactive. We have Dr. Kevin Boyd's course. I know he's on now. Hi, Dr. Boyd, but we're so excited for this course because it's a technique course. It's very similar to Dr. Miraglia's structure on we're going to learn how Dr. Kevin Boyd, with his 30 years of his tried and true techniques, he's going to organize it in such a way, breaks it down, simplifies it, so you will know how to use like BioBlock type of appliances under 6 years of age. So like that 3 to 6 year group. And he'll also talk about strategies with pediatricians, getting the medical community on board and how to have the parent consultations with that young age group. Our special guest is going to be Dr. Darius Logmany on Saturday, April 2nd. This is going to be in sunny Florida. It's also virtual. So hopefully we can see you there, but you do need to take our mini residency with Dr. Ben first as the prerequisite. If you're interested in advanced techniques to get the whole spectrum, we do have our advanced course where Dr. Miraglia will teach you the brackets and wires and fixed expansion, as he mentioned earlier, from about 14 to 19 or so. That's 100% virtual as well. And I want to show you some upcoming conversations. Next week is, in 2 weeks, Dr. Boyd, February 2nd, is their right age to start interceptive ortho. So that will be a very compelling conversation. And since February is Airway and Heart Health Month, we're going to have Dr. Nelly Silva, who is an AHS alumni. So we welcome her to the platform. We'll answer all your questions. There are a couple tonight about heart health and airway, so that'll be answered then. Dr. Michael Gelb will be joining us March 15th, talking about the TMD patient. We have a special announcement coming up soon about Dr. Gelb, so stay tuned for that. And March 23rd, Stewart Center's own Dr. Hal Stewart will be talking about airway-centered restorative dentistry, March 23rd. And another important topic, probably not spoken about as often as it should be, is the impact of allergies on pediatric airway disorders with Dr. Susan Maples. So stay tuned for the invites. It's really a lot of exciting stuff going on. And just so you know, we partner with Ohlendorf Appliance Lab, just because Dr. Miraglia has been working with Kevin Ohlendorf. A lot of you know him for 16 years or so. So he's truly teaching his tried and true techniques of what he does. And we do that with Kevin. So once you take our course, we've actually created scripts for you with the Airway Health Appliances. So it's customized to Ben's preferences, but also now we're introducing aligners. So this is a special announcement tonight, especially for our alumni, that we will be sending out follow-up information on learning more about our aligners for those who are AHS trained. So if you have any questions right away, but we'll send you the information. You can email Kevin or myself, but it's an exciting time that we're really excited to add that to make everyone's life a little bit more simple. So that's it for us. I know we have another perk of taking our courses. You become our Airway Dentist alumni, and you become an Airway Dentist part of our community, which we're having a town hall, a private town hall, where it's more intimate with everyone, kind of just chatting it up back and forth with some questions. So we're going to jump on for all of our Airway Dentists. We'll see you at the next meeting for the second half of the Q&A. And for everyone who joined us tonight, thank you so much for your passion. I see all of our participants, 72, stayed on for the whole night. So thank you guys. And we appreciate your passion. And Dr. Miraglia, keep shining, because all these comments, I don't know if you can see while you're talking, everyone's just thanking you for your passion and spreading the word and helping kids grow into healthy adults and helping adults not suffer and live the life they're supposed to live. So thank you for doing that.
Thank you. Thanks for listening. Let's help some kids.
Yeah, and we'll do this occasionally because I like this mixed bag. I think it's fun. Everyone gets to learn little nuggets here and there, but take our mini residency to kind of piece it all together. So hopefully we'll see you soon, and we'll see you for Dr. Boyd's February 2nd, and we'll see our AHS dentists. Now you have to sign up. The link is on our Facebook group or in the email we sent. So we're going to hop off this and hop on to the Airway Dentist group. Thank you, everyone. Good night.
Good night, everybody.